Is everyone ready? Miss Teo, are you going to continue now, or you want a bit wait for a bit? Okay. All right.
So just now I have questions of does the origin same with the plant isocenter? So for this case, just now the L3 L4 case, remember when we first import our city image, we already identify the origin. So for this case, my origin is at this slice where my isocenter is here. So the blue color point is the origin and my red color point is my isocenter. So when we want to export the information to the radiographer, so we need to tell the radiographer how much they need to shift from their origin to the planned isocenter. So for the system, we can generate from this tab. So this one, just now we already logged the scan reference means our origin. So here we will need to select plan isocenter. Plan isocenter which this red color point. So our plan isocenter is actually at the slice 15 cm and 0 cm Z. So I can scroll. Okay, this is the isocenter slice where the red dot there. You can counter check at here left bottom here 0 0.05, 15 and 0.12. So it's exactly the same number. So after you click the plan isocenter, we will need to send this this shift information to our radiographer. Means they will need to shift 15 cm superior from their origin. So normally we will print this document. So for them to counter check, let's see sample. Yeah, this one I don't think even okay. Okay. So the radiographer will according to this to shift the patient. Of course, it's very important here is you have to make sure your scan reference, the origin is correct. And point the plan isocenter is correct. There is some incident at our center where the physicist select the different point for the plan isocenter. So when they do the treatment verification where I mentioned just now the port film and the CPCT, they will find the patient plan and the patient position is different. So from there only we find out the information actually the physicist print is incorrect. So after that, then we have to very careful when we print out this information, and of course the third party check. You have to double check the coordinate point with the plan documentation. So the plan isocenter is actually you can place anywhere else, but the important is don't shift it too far from the origin. So because when when you lie down on the bed, the position it may it may misalign a bit. So my radiographer is actually very experienced. So when they see the doctors want to treat so many sites, maybe from cervical until the pelvis, so they will actually mark two origins, where at the maybe one at the thorax and one at the pelvis, so to ease their works lah when they set up the patients. So this one is a how to say is their initiative to how to make sure the plan is correct and how to save their times, so they don't need to repositioning the patients. So but this one we will experience, this you will be experience it at later when you work. So now we move on to do I answer your questions just now? Who Asila, I think is.
Yes, Miss. I
So
understood.
so you understand now, huh?
Yeah, yes. Thank you, Miss.
Okay, so now we move to our second example case. Actually, the second case is the same. It's just I change the prescriptions from one beam technique to two beam technique. So maybe I will just use back this L2 L4 case to do some adjustment. So just now for this case, we only use one beam technique. Maybe I can, okay, it's okay. You can save another plan so later you can see the difference. So for this case, Dr. Wan, just now remember when for this case, the coverage when we prescribe to 5 cm depth, the coverage is only 70% at the vertebra. So after the doctor reviewed the plan, he said, not enough. I want 100% coverage at the vertebra. So now, how should we do that? Because impossible, we put our weight point, means the prescription point at the vertebra here for one posterior beam. Because just now you see when we point the prescription point at 5 cm depth, the posterior part is already 15% higher, the maximum dose. So imagine if I put 10 cm depth here, example, I want to cover the vertebra 100%. So imagine how hot it will be at the posterior part. So maybe you can't imagine it. So let me show you. So let's say this point, Dr. 100%. Okay, just 0.5. Okay, so now the vertebra is covered 100%, but let's look at the maximum dose of these plants. Maximum dose is 32.9 gray, where how many percent is it? 32.9 gray divided by 20. It is 64.5%. Don't you think that is a super high dose where it will hurt the patient's bone marrow and it may cause a burns at patient's skin? So how should we do now to make sure our plan is 100% as at the vertebra as doctor require? So now we can apply the two beam technique. Just now is one beam from posterior only. So now we can actually add another beam from anterior. So normally, if you want to be a quick, we won't click new beam lah. So we will oppose this beam. straight away oppose this beam, so it will actually copy all the field size from the posterior beams. So I will duplicate and oppose, so you can now see the gantry angle change to 0. So I will rename, delete. I rename this one to anterior. Okay lah. So now you can see at the plan, there's a red color beam indicate it is a anterior beam. The purple color is the posterior beam. It actually depends on when you click anterior, it will go red color. And you go posterior, posterior beam will become red color. But this is not a big matters. So now we want to prescribe, doctor said want to prescribe 20 gray in 5 mid-plan dose. When we see mid-plan dose, the short form is MPD. We will immediately know doctor want APPA technique, means the anterior posterior technique. Means he want the mid-plan of the patients is getting 100%. Means if patient separation is, let's say 20 cm, the 10 cm he want to get 100%. So for this patient, the separation of the patient body is, can see 24 cm, I think. 24 cm. Okay. Before that, I forgot to mention just now. Actually, at rules of thumbs of, you can say, basic in treatment planning, when you want to place a field, at those days we will put mid-plan. Means if the patient body separation is 20 cm, you will put your ISO center at 10 cm depth, and if laterally 30 cm, you will put your ISO center at 15 cm, like that. So you will see exactly the red color ISO center is at your center. Like for example, this patient I shift mid-plan for you. Just now is 24 cm. So I need to go to the mid-plan where is 12 cm. So I have to put my ISO center at this line. So now I need to shift my ISO center to that line. So if you want to get a quick one, you can straight away do like this, so you no need to guess where is it. So you need to know this sagittal plan is actually Z coordinate 3.5 cm. So at the ISO center here, you will need to put here 3.5 cm. So when you change one beam, it will automatically change to another beam for you, because we already link all these two beams. So this is the mid plan. So for basic, this is how we plan those days at the 2D time. So for now, because we want to fast, and when you are very experienced, you don't need to do all this, because we can actually just change our prescription point at the 10 cm depth. But for now, I'm better to show you like this. I scared I'm confused you, because at first I'm confused when I first joined the another center. So okay, now the field is still cover L2 to L4 area, but now we using anterior and posterior two beam technique, and the ISO center is at the mid plane, so we can actually prescribe to the plan ISO center, because this one is already your mid plan. So plan ISO center 20 gray in 5. So now what is the percentage we want to contribute from posterior beam and anterior beam? I'm going to show you now is 100% from posterior. So you will expect all the dose from posterior and the isocenter point get 100%. And this scenario is actually just now where doctor want to cover the vertebra 100%. So let me turn on. Okay, 100% at your isocenter point, the orange color, but it's super high dose at the posterior. So now, how much percent want to the and so normally for this kind of case, we will put it equal if 50% from each beam. So when you look at this, our isocenter is still cover 50%, and the yellow color 95% is covered all the region L2 to L4. And then, okay, this is the plan what doctor means, mid-plan dose, so 100%. But just now, you all asked me when to choose 6 MB and when to choose 10 MB. For the RTOG criteria, remember I mentioned the plan evaluations for the OLR, DVH, we follow RTOG criteria. So there is a criteria said that any of the plan you shouldn't the maximum dose of the plan shouldn't exceed 110% from the prescribed dose. So for example is this plan we prescribe 20 gray, but the 10% dose, the maximum dose you cannot more than 22 gray. So for this plan, the maximum dose now is 23.37. That means 23.37. It is now almost 17%, which it is already exceed the criteria. So how can we reduce this one? So for this plan, we are actually using 6 MB. Remember the 6 MB, the Dmax is 1.6 cm, and for the 10 MB, the Dmax is 2.5 centimeter. So for this kind of case, we will change it to 10 MB to reduce the maximum dose. So as a quick reference, where the patient body separation is more than 20 cm, we will immediately know this patient needs 10 MB beam. Like for this patient, just now the separation is 23 cm, 24 cm. So actually I immediately know he will need 10 MB, but to show you all, so now I change this to 10 MB. So let me calculate and see what's the difference. Just now the maximum dose is 17%. So after we change to 10 MB, let's see what is the dose. It will definitely reduce the maximum dose. As you can see here, the red color just now is quite a lot from anterior and posterior. So now the maximum dose is 22.426. 22.426 is actually 112%. So for this situation, it exceed the the RTOG criteria 10%, right? But because this one is a palliative case, we have no choice. We don't want to make the plan more complicated, so we will just accept this 12% highest. Because the prescription dose is only 20 gray in 5 and it's only 5 fractions, so the side effect is not much significance where you compare to the normal radical dose. So for this kind of patient, the most they have the chance diarrhea, and because you see the higher dose here, 107% is at the intestine. So means when we do the radiotherapy, the dose go into the intestine where patient may have diarrhea afterward, but mostly it's very less, only 12%. So normally for palliative case, doctor understand this kind of situation, so they will just accept it, unless if because this one is palliative case. Palliative case means we aim to reduce patient's pain only. So the ultimate goal is reduce the pain. So the diarrhea side effect is not a much concern in this kind of case, because maybe just diarrhea for 1 or 2 days, then it's okay, and then this one can be stopped by taking medications. But the bone pain where it eat by the cancer cells, it cannot stop by taking medications. So for this case, then 12% is okay, can be accepted. Then doctor approve the plan and we can proceed for treatment. So for the how to make sure your plan or your target is getting 100%, unlike just now when we point at the vertebra, it's only getting 60 or 70% coverage. So for this case, with the 2-beam technique, we make sure that the vertebra is covered 100%. Actually, for this here, you can see, okay, how about this slice? You see, the orange colors is not covering the vertebra. It's not 100% over there. Do you think we need to adjust to get it 100%? Do you think we need to adjust it? Okay, the answer is no need. There's when you put the beam, there's a divergence in your theory base. You have learned about beam divergence, beam penumbra, means at the edge of the penumbra. So definitely the edge of the field receive 1% less.
Your voice is
Sorry?
like a bit cracking.
Oh, so where should I repeat? Okay, I repeat where you learn at the theory based, there is beam divergence and penumbra at the edge of the field. So it's very common when you see our beam here. Look at my pointer. The 100% is not covered. It's not fully 100% covered at the whole beam, the field size. This is the noise is a very normal thing, because and thus the RTOG criteria is mentioned one, at least 95% coverage at the tumor area. So for this color, the yellow color is 95%. So we actually is already cover 95% of the treatment area. So we will just accept this plan and continue treatment. So, but if this patient is example 4, example 3 and example 4, you will need to more specific coverage, means the 95% coverage at the target area. So so far question for this example case is actually I'm already done for this case. Any questions?
No, Miss.
No, miss. So can I proceed to the next example?
Yes.
Okay.
Yes.
So for our next example case will be the pelvic case. So it's a 4-beam. So we are moving from palliative case to radical case. Radical case means we aim to cure the patients. So radical case, we will need at least 95% coverage to 100% coverage of the tumor. So then okay. For pelvic case, which is cover for men pelvic case, cancer rectum, cancer prostate, cancer bladder. Okay, for women, cancer bladder, cancer rectum, cancer uterus, cancer cervix is the most common lah. So when we there is different coverage, there is different treatment area, treatment region for like CA prostate or CA rectum. So you will need to read this, which area you want to cover from, means the superior border and the inferior border where you should cover, but I'm not going to explain this in details here. You may find it at the treatment planning books lah. But I'm sure when you go into when you work as physicist, your senior will teach you. So for this pelvic case, we are going, for example, we are going to prescribe this plan. This is a CA prostate plan. We are going to prescribe the dose at 25 gray in 5. Actually, there is a lot of prescription, but this one doctor maybe want high dose radicals, but it doesn't matter lah. This one is just an example for us. So normally for prostate plan, we will do a 4-beam technique. It's unlike just now, we only do posterior or 2-beam technique at PPA only. So now we are moving from 2 until 4-beam. So for the anterior beam, this one is okay. I already put in the fields to save the time. So for anterior beam, we will need to cover from L5 S1 junction until the prostate area. For this case, actually, my doctors is already contour the prostate PTV. So we will need to make sure our treatment field is cover wherever the doctor contour the PTV. But this one is just actually this one is a phase 2 boost area lah. So for the phase 1 we will need to cover from L5S1. When I say L5S1 region means the vertebra between the L5 and S1. So this is the L5 and this is the S1. So our beam will be in between this line. So we have to put the superior border from here until we cover the Dr. PTV. So this is our superior border and inferior border. As for the lateral beam, we will need to cover 1.5 cm from the sacral region. I will use some medical terms where you might not understand because this one require a lot of study at the how do you plan, which area do you need to coverage. So but for example, I already put in the field. This is the area I will need to cover, and I'm not going to touch the MLC yet. Okay, so for this is anterior field. So for the lateral field is the same. The lateral field, the important here is the superior and the inferior border must be the same. So for the anterior border and posterior border, remember when you look at the lateral beam, the terms is different now. So the anterior is here, the posterior is here. So the anterior beam, you need to cover at least 3 cm from the vertebra and or the pubic bone. You need to know where is the pubic bone, where is the para-aortic node. This one is a bit difficult for you, but you need to learn later lah. And then the posterior field, you will need to cover at least S2 and S3 junctions. So you won't miss any target. So, okay, for this field, I already duplicate and oppose the beam. So, prescription is 25 in 5. As previous case, so for this case, I think I already put at the mid plane from anterior and posterior. So normally when we first, we already define which area, which field size we want to cover. We will show to doctor first. Does the field size you put in is correct? Is the coverage enough? So doctor will tell you lah, if this is okay, then you will proceed for the calculation. If not, he will tell you, okay, increase superior 1 cm, reduce left lateral 1 cm. So you need to listen carefully and mark it down where doctor want to change it, because sometimes doctor is just verbal call and remote like we are doing now, remote and tell you where, because doctor is very busy. He's not sitting in the radiotherapy center only, he is sitting at their clinic. So normally at our center they will just remote from their clinic to tell you. So okay, for example, this kind, okay, doctor says, okay, you can proceed for the calculations. So now we look at the dose and see the dose. We have to show this plan to doctors. So normally we will first equals the weight, means each field we will contribute 25% first. So let me see. Okay, this plan we will use 6 MB first. 6 MB first. Okay, prescription, double check the prescription, 25 in 5. Equally weights contribution. So we I already calculate the, okay, I already calculate the plan. So now let's see what is the dose. So we are now prescribing 25 in 5. I'm going to change this one. Okay, this plan, as usual, we will see the ISO center point will get 100% coverage, and the 95% is covered nicely from your field. Here, the sector region area, we wouldn't want it very high dose here because of the bone marrow productions. So normally if the 95% is covered like this, following the curve of the sacrum, it should be okay. So how can we how to say, are you satisfied with this plan calculation with each beam contribute 25%? So for me, because this one is for me, I will first 60%, okay, 70%, 60%, okay, 70%. You can see the what's called light blue color here at the right extreme is a little bit 70% dose here compared to the left lateral patients. So it means the dose is not homogeneous. So we may reduce the right lateral beam dose, the percentage weighting to another area. So now I'm trying to reduce my right lateral dose from 25 maybe to 23. So now you can see it's jumped from the 70% is gone, is covered as nice as just let me off this one. The 70% is exactly a 4-field box. The 4-beam technique, we will call it as 4-field box techniques. So because the dose where the dose distribution is become a 4-field box. I think this one you also learn from the book. So the 95% and the 70% is now the 4-field square here, or from all the region, all the treatment area. So now, am I satisfied this plan? I'm not really satisfied with this plan because you see my doctors contour the PTV, the yellow color, this prostate is actually 95% coverage, but you can see from the sagittal view the anterior and on or at the anterior compared to the posterior. So now I want to make it more homogeneous from the and anyone have anyone? The example is the example is like just now when I try to reduce my right lateral beam, I reduce the percentage weighting. So at the same conditions, how should I distribute more equally from anterior and posterior? Anyone want to answer the questions? Okay, so I will now, the answer is I just reduce my, I will take some of the percentage of my anterior beam to my posterior beam. Remember when you adjust your percentage weighting here, let's say from 25.67 to 20, the 5.67% difference, it will equally dump to another 3 beams. But now I only want this anterior weighting. I want to dump it to posterior only. So I need to lock my lateral beam weighting. I don't want my percentage dump to others. I only want it to posterior. So let's see. And I reduce to 23%. I just show you a bit by a bit, like I don't want too much. Okay, now my 2.67% is actually contribute to posterior beams only. You see, when I reduce my anterior weighting, my plan is now is better, equally contribute to the my dose is more homogeneous now, the anterior and the posterior part. So you can see, okay, okay, maybe this slide is not, so maybe you can try to reduce a little bit more. Okay, okay, okay. So now the anterior posterior is equally, I can say it is equally contribute. The dose is very homogeneous, homogeneous for the 100% dose coverage. As for now, this plan is actually, you are ready to show to the doctors. Unless you want to do it more. If you want to do it more, you can play around the weighting. Now the anterior and posterior is okay. How about the lateral? Normally it depends on different doctors. If you tell you, okay, now my 70% the blue color is cover very nice fill box, and accept this plan, and you may proceed to treat patients. So then you can, very happily, you can send this plan to your radiographers. But okay, now we already approved this. How can we improve this plan further? If you remember just now, and when I click my 60%, it's not equally, I aim to push all the 60% into a fill box. Okay, you may notice this patient actually is quite a bulky patient where the belly is quite big. So there will this type of patient you will need to play more weighting at this kind of patients. So now, how should I reduce the 60% is equally? Okay, as I mentioned just now, I already dumped the right lateral dose to others, but now I want to make it more equal, or I want to make it more for the box. I want to make the 60% into a box fills more homogeneous. How can I do it? So now we will try to lock the anterior and posterior beam, because you already satisfied with the anterior and posterior weighting. Just remember, when you play around this weighting, you need to pay attention to how the dose change. You have to really mark it down, what have you changed, because I see quite a lot of junior. Okay, this okay, when they changed from 23 to 20%, they don't remember how much they change, because after they change to 20, the result is not actually as good as just now. So I will tell them, okay, you change back to the rating just now. They do not know what they have changed. So you have to pay more focus and attention to this, whatever you play around, else it will just waste your time. Okay, now I want to equally. So now it's very obvious that my left lateral 60% is more than the right lateral beams. So I try to increase back a bit for my right lateral. Okay, now it's equally. So for actually this plan is already okay with 6 MV for ton, based on my experience. So if the doctor said, I don't want this 60%, how can you do it to make it nicer? How can you do it? Anyone can answer me this one? It's related to it's related to PDD and the previous example where I show you just now. Anyone? How can I modify this dose? How can I reduce this dose? Okay, the answer is I can change the lateral beam to 10 MV. The tricks here is it doesn't mean all the beams you have to choose 6 MV. You can break this anterior posterior 6 MV, and then the left lateral or the lateral beams 10 MV. As you can see, the separance between the anterior posterior just now is 24 cm, the lateral is 33 cm, 34 cm. It's definitely bigger than the anterior posterior separation. So let's see, when I split the beam, the lateral beam to 10 MV, thus my 60% will go off. Okay, now our beam is, let me arrange so you can see better. So now my beam is anterior posterior 6 MV and lateral beam 10 MV. Let's calculate. Okay, it's only reduce a little bit, but it actually can reduce. You just need to play around with your weighting, where you change your lateral weighting to anterior posterior, which may cause you the anterior and the posterior more hotter. So now you need to identify, you need to justify what kind of dose distribution you want. As I mentioned just now, when you put anterior or posterior weighting more, patient side effect will be diarrhea, and the posterior skin may a little bit sunburn compared to the lateral beam. So as you can see, the lateral beam here, the entrance for this beam actually is just muscle and soft tissue. So it's okay when we burn this area. So for this plan, the patient will definitely lose down their weight. I have one patient treat pelvis the outcome, he said, wow, this is a very good slimming package, because it's really slimmed down a lot because we burn the belly and the soft tissue. But the aims, of course, is not the slimming effect lah. So now actually this plan is already okay, and then now you need to show to the doctors. So actually, before we change the lateral beam to the before we change the lateral beam to the 10 MB, is actually already satisfied with the those distribution. For as a physicist, you need to self-identify and justify that the plan is good enough. And secondly is, does your doctor no, you have to understand what is your requirements from your doctors. Different doctors have different criteria. Some doctors don't even see the 70% is the fill box distributions. But as in our center, we will already used to this, so we will make sure the 70% is in the fill box lah. So as for this, it's already okay. We can proceed. Doctor said, okay, proceed for the treatment. So as usual, we will and proceed the treatment. So as far for now, any questions?
Yes, I have a question. So does this mean if we want to make the plan, we can make a choice whether we want to do it 6 MV or 10 MV, but it depends on how we justify the treatment plan, right?
Sorry, repeat just now the last few sentence. I can't hear you.
Okay. As what I want to ask is, in we can easily we can choose between whatever we want to choose, either 6 MV or 10 MV. Depends on how we justify the treatment plan and the outcome of the patient, right?
Yes, yes. But of course, when your doctor asks or your senior physicist asks, why this plan? Because some of the center they don't really mix the photon like us. So they will definitely ask you, why this plan you put the lateral beam 10 MB, where just now actually 6 MB we already achieved what doctor criteria, right? So that you need to answer lah. You need to know how to answer why you choose 10 MB. This is because the patient separations is high, is big. I aim to reduce the lateral dose. You have to answer like this. So if they said no need, I think no need to reduce the lateral dose. So you just put back the beam to 6 MB. If your senior said that, will you put that back, or you straight doctor is already approved the plan? What in this kind of situation, what do you do? You need to justify lah. You need to give a very strong reason why you want to do that, because some senior they already used to their pattern. They don't want like a very complicated, so they may not accept your plan. But the doctor is actually already accept your plan. So when you actually want to for of course lah, when before you want to show your plan to your doctor, you have to show your plan to your senior physicist first. If you can persuade your physicist why you want to do this and that, then for sure the doctor should be not a problems lah. So for my center, the junior will explain to me first. If I find the explanation is reasonable, Then I said, okay, you may proceed to show it to the doctors, because sometimes the junior may have more idea, more good planning than senior. It doesn't mean the senior will produce a better plan. It's not. You have to remember this. But I'm not asking you to fight with the senior lah. Okay, you need to justify very a strong justification. Okay. Am I answer your questions?
Yes, Miss. Thank you.
Okay. Any other questions? Actually, for this plan, you can actually straight away use all the 10 MB. Let me show you if we use all 10 MB. What is the difference? Wait, let me save. Let me save all 6 MB first. Yeah. With the same weighting contributions, but different energy. Let us see what is the difference. Okay, this is the 6 MB. And now I change it to 10. Bit slow. Are you Ahmad Faiz? Are you a master student or degree student?
I am a master student.
So you are
Miss,
going to grad this year?
inshallah, yes.
So okay, very good. I can remember you now. So maybe next year we have a chance. If we open vacancy, you can dump in your resume. This is the pro and cons when you keep answering my questions. I can remember you.
Yes, Miss. I look forward for it. Thank you.
All right, so now I show you the difference between 6 MB and 10 MB. Wait, let's see. You can always compare your plan by saving different name, so you can see which one is the best plan you can choose. I cannot calculate because side A never. Yeah, I have to delete side A. Side A, so ish. Give me 3 minutes. You may ask any questions while I'm calculating for the plans. It's a little bit slow. And then for your radiobiology course, radiobiology course is actually we learned it at third year or master, I don't remember. There's a equivalent dose. Do you study that? Because for today example, all the dose per fractions is actually higher than the clinical dose. The clinical dose, the standardized dose is 2 gray per fractions. But for today, all our example is 5 gray, 4 gray. So you need to know how to convert it back to the equivalent dose. So that actually there is a quick formula for you to calculate. Let me write it down. How to write it down? Let me see. You can mark this down. The EQD2. The 2 means the. Let me open my whiteboard. How do I change this? New. Okay. The formula equivalent dose to 2 gray is the prescribed dose times dose per fraction plus alpha beta divided by 2 plus alpha beta. So at here, the alpha beta, you have to choose which alpha beta you want to use. But for different organ at risk, the alpha beta is different. But normally, alpha beta for normal tissue, we will choose the number 3. If for tumor, we will choose 10. So in most of the scenario, we will calculate for the organ at risk. So we will choose 3. So please mark this down, this formula, because later I want you to calculate the dose for me. Okay, when you're done, you please tell me. I will turn off this board.
Miss Teo, they learned about this actually, and there's even a test question yesterday about this.
Oh, okay.
I just
they learn, but they may not how to apply.
but may not know how to apply. Yes, yeah. I was about to ask you as well. How do you apply this? And also like because what I remember is sometimes the doctor use the BED. Sometimes it's actually the EQD2. So can you explain what are the difference between the two and how to apply? Yeah.
Doctor use BED 10. They want to see how much actually the tumor will receive the dose. Means which this will affect in the radiobiology. But in one plan, the most important is not the tumor, I cannot say like that. The important things is also to the normal tissue and the tumor, but we will put the priority to the normal tissue first, because like let's say the example, the spinal cord is maximum dose is 45 gray. So when the patient receive more than 45 gray at the spinal cord, what is the consequences? The patient may paralyze, or depends how much the dose you exceed lah. If like let's say 50 gray 1%, the effect is not much different. If the patient receive, like let's say you tell me your plan, the spinal cord is 60 gray, so I think the patient will definitely paralyze, because you already hurt the spinal cord, you already damaged it. So for another example is like parotid gland. Do you know what is parotid gland? The gland where we produce our saliva. So the mean dose of the both parotid gland is 26 gray. So at the head and neck plan, we have to achieve this 26 gray for both parotid gland. Somehow it's quite difficult to achieve this criteria. So if the parotid gland is damaged, so the side effect where will cause to the patient, they will their saliva they will reduce, where they will develop xerostomia, means their oral cavity will always very dry, because the parotid gland, they cannot produce the saliva already. It's not as now the normal patient, the normal persons. So they will forever very dry mouth when the dose to the parotid gland is very high. So come back to this equivalent dose, because now the new era is hyper fractions. So hypo prescription too. It's not like those days we prescribe every fraction is 2 gray per fractions. Now the trend is 3 gray, 4 gray, 5 gray, even 12 gray. So as a physicist, we need to know how to calculate this one. So when you do your plan, you need to, because when you do your plan, we need to evaluate the DVH. So later I show you another example, how do you do this. So later, so now we go back to our plan first. Okay, for this plan, okay, for this, let me show you. For the left side is 10 MB, for the right side is 6 MB. So for this patient, the only difference is you can see the lateral beam, the dose. I think for this beam, for the 95% and 100% coverage is not much difference, but the lower dose region will be a lot. Let's see, 30%. Yeah, cannot see. Okay, so 30% cannot see. Yeah lah. For these two brands, the most significant is the 60% coverage lah. You can see the 10 MB plan is actually reduced more on the lateral. So means patient is not slimming a lot. It's just a joke. For the 6 MB plan, patient will slim a lot. Okay. So for this patient is not a very good example to show you the difference, because this patient is very big size. So okay, Are we done for this example? Or else I will jump to the equivalent dose first before I proceed to another example case. Okay, everyone okay? So now you can calculate me my whiteboard. Okay. Just now, all our prescription is 20 gray in 5 fractions, which the dose per fraction is 4 gray. So what is the equivalent dose to this prescription? You can calculate now. I give you 3 minutes. If you have the answer, you can type in the chat box or you can straight away answer. Okay, I can see the answers now. 23.3 gray for tumor and 28 gray for OAR. Yes, you are correct. So for these prescriptions, actually the dose actually received by the patients for tumor is 23 gray instead of 20 gray, and for the OAR is 28 gray. So you means the OAR is 28 gray, I remember. So for these situations, the spinal cord is still within the tolerance 28 gray. If let's say, okay, questions 2, let's say 45 gray in no 40 gray in 15 fraction. You just calculate me both lah, the tumor and the OAR. Okay, the answer is correct, 45 and 42. So for the prescription of fortigray, you may need to pay attention to your OAR DVH when the spinal cord is more than 40 gray, means you have to reduce your spinal cord dose by changing your plan or change the weighting contributions. So this one, as a physicist, this is a basic to know lah. You have to keep in mind this formula. You have to this formula will follow you forever ever. You need to know this. So when doctor asks you to calculate, you can straight away tell what is the EQD2. Of course, there is a lot others formula, but it's not like gap correction. I believe you all already learn that the gap correction, but that one not in, maybe when you work only you will relearn against lah. The theory is a bit difficult to apply in the actual situations, but for this equivalent dose is super important. So just memorize this formula. Any questions?
Miss, I have a question about EQD2 actually. From what I realized,
Mm.
if we do hypofractionation, right? If we do hypofractionation, we
Mm-hmm.
tend to realize that the dose to OAR is
Mm-hmm.
higher compared to tumor.
Mm.
So usually, if I may ask, if that kind of situation is like the EQD2 dose for OAR is higher compared to tumor, do we
Mm-hmm.
usually use it? Do we usually use it also,
Do we
knowingly
use
that?
you means now the tumor is actually receive low dose?
Yes. Usually, is it because of usually for palliative, right?
No, it's for all the case.
Or the case.
It's not only palliative. Radical also you need to know this one.
Okay, miss. Thank you.
So for this case, you evaluate the OAR, because this one is the very serious effect to the patients, where if the serious organs is already injured compared to the tumor, patient have no any more quality of life compared to if they already cure the tumor. If you already cure your brain tumor, but you cannot walk, you have to bedridden forever, will you choose that? Definitely, I don't think you will choose that lah. I will love to choose the balance of my life with where I can still live as normal. So this is the balance between the tumor and the organ at risk. So and then the another things is you have to study more deep in radiobiology. The tumor is actually much more sensitive than soft tissue, where even though we only the tumor is only receive 42 gray, but the radiotherapy effect to the cell sensitivity of the tumor is actually faster than our OAR. You remember there is a 4 phase in our repopulation, the cell generations. I don't remember, but I remember it's 4: regenerate and reoxidize, reoxygenations, all that things lah. When you study more in the radiobiology, you will understand more in this. Okay. So now we will move on to the last case, right breast where I will show you the difference of the wedge and the fill in fill technique.
Miss,
Yep.
hello.
Yes. Yeah.
Miss, can I ask something?
Mm.
What will happen if the dose for EDQ EDQ EQD2 for tumor and OAR is same, which means 40 gray or yes. Is it the tumor still get the effect or how?
Yes, the tumor will get, the tumor will get the effect because those day we treat 2 gray per fractions. Then when the scientists, the radiobiology scientists, they do the research, they find actually they will kill the tumor cell will kill faster than the 2 gray. Means the effectiveness is still there compared to the 2 gray per fractions. So that's why now actually for the breast 40 gray in 15 fractions is actually is a CA breast prescription. Those days we used to prescribe 50 gray in 25 fractions, which 2 gray per fractions. So but now we reduce it to 40 gray, where the radiobiology scientists they find the this patient actually the outcome is equivalent to the 50 gray. So actually this prescription dose is throughout a lot of research. Then only they will publish in paper and telling whole world that this actually 40 gray in 15 fraction is work. So as for example, for the COVID pandemic, there is another new dose coming out for the breast. We actually reduce the prescription dose to 26 gray in 5 fractions. So you may calculate me 26 gray in 5 fractions is actually what is the equivalent dose? 26 in 5. Twenty-six in 5. The breast dose is now for the COVID pandemic. For the COVID pandemic, because we want to restrict the patient, don't visit to hospital as much as possible. So we reduce the fraction from 15 fraction to 5, but the prescription dose is 26 gray in 5 fraction, which means one fraction is 5.2 gray compared to the previous is 2.67. It's like double up the dose per fractions. So okay, there's the answer here. For the EQD2 for OAR, the dose is still, sorry, anyone's talking? So for the OAR dose is still the same 42.6 gray. If you is the same with just now. Just now the 40 gray in 15 fraction is 45 gray. So now the OAR is 42.6, while the tumor is only 32.9. So 32.9 is for the tumor equivalent dose. So the tumor, well, after we calculate the tumor equivalent dose is actually is very low for the compared to the 40 gray in 15 fractions. But you don't forget what I said just now, the radiobiology effect in the tumor cells is different from the normal organ tissues. So when the scientists find this, actually we find quite our center is actually treating all these 26 gray in 5 fractions now. We find the outcome is not as soon as is not is you can't see it here now, because the COVID is just 2 years. Maybe we have more report on maybe next 2 years. They will gather all the data to show if the output of the CA breast with this prescription dose is good enough. But so far for this COVID pandemic, we have not really a good choice. We have to reduce the visiting to hospital, so they come out this one, which I think when they publish this, they have the confidence in the prescription dose. So there's the equivalent dose lah. But equivalent dose, we will pay more attention on the OAR lah. It's not the BED lah. It's not the tumor dose. Okay. Any others questions? Else I will move to others.
Okay, thank you, Miss.
So now we go to the right breast scenario. So as the same as the pelvic case, I'm not going to tell you superior and inferior border you need to cover, you need to study this one yourself. But the basic plans, we will do this just now is APPA plans, mean anterior posterior. So for breast, we will use tangent technique. So tangent technique means a tangent beams lah. This one to avoid the lung dose, the heart dose, the liver dose. So from this technique, we will actually, after we define the treatment field for the breast, is actually look like this one. So the field size for standard breast field is from 17 to 20, depends on how big the patient breast. So for these patients, this is a foreigner lah. So after I put in the field, I found the treatment field for this patient is roughly 17 cm, the length. So it doesn't matter as long as we cover the breast, the whole breast. So those days, doctor will mark for you the superior and inferior border. But then now we need to define ourselves where is the superior and inferior border, which I tell you just now, we have to study ourselves, or your next time your senior physicist will teach you how to justify it. So for this plan, if you notice for this patient with the tangent field technique, you will notice the irregular field. The patient body is not flat, of course, because of the breast contour. So for this kind of case, how can we, wait, let me turn off. Okay, this is a case where I already calculate the dose. The important in breast field, we need to minimize the lung dose. So there's a rules here. The maximum lung dose, the maximum distance from lung to the chest wall. You can see at the right top DR here, the maximum from the chest wall. This one is the, let me show. Yeah, this one cannot see. Okay, this is the most clear. So when you see here, this is the chest wall. This is the darker color here is the lung. So the maximum distance from the chest wall to the lung is actually 2 cm only. But of course, in some criteria, in some situation, doctor may accept up to 2.5. But in our plan, we will put it maximum 2 cm first, and then only ask doctor to justify how they want. So breast pen, it seems is very simple, but actually is complicated too. So for this plan, the prescription is 40 gray in 15 fractions. So after I calculate, I found the, let me see the maximum dose. So 43, the maximum dose for this plan is 43.9 gray. Is actually almost 10% of the 10% higher of the prescription dose. But remember just now I tell you the RTOG criteria is 10%, cannot receive more than 10% dose higher than the prescription. But in our centers, the palliative case only we can receive 10% higher dose. For all the radical case, we can only receive 7% higher. So in this case, it's already more than the 7%. And if you can see, the dose distributions is not homogeneous. So now I need to do something to make the dose distribution is more homogeneous. Anyone have any solutions for me? What can I do?
The wedge?
Huh?
Wedge.
No, yes, you can use the wedge because of the contour here. You need to how to, okay, you need to add a wedge here like this. The thick end will be facing outward to make it back to the square like this. Understand? So if we use yeah, if we use the thick if we use the thick end like this, sorry, how to draw this one? Okay, this, we will actually push all the dose towards the patient's skin. Let me show you the example. So for this plan, okay, I already pre-put in the wedge. So how do we justify the wedge angle? So when we plan, remember just now the physical wedge is only 15, 30, 45, and 60. So when we plan, we will straight away, for my experience lah, I will try it with the physical wedge dose first lah, because where the people invest this kind of things, there must be a reason. So I will straight away use 30-degree first, because for the contour of the patient, 15-degree is too thin. So when we want to use the motorized wedge, you will need to turn your collimator. Let me show you the example here. So, okay, here, when my collimator is 0-degree, my wedge is actually in these positions, where I will push the inferior dose to the superior, where it's already wrong. Because just now what I highlight at here, we want the thick end at the outward of the breast. So I need my wedge angle to be like this, as in the purple color. So when I turn my collimator, okay, if I turn 90-degree, the thick end will be opposite way. So we need to know. It's okay if when you first join as physicist, you do know the collimator angle. You will just play around with the angle. It must be 90 or 70. It must be 90-degree or 270-degree. So you just play around. So okay, now the collimator angle 270-degree, and my wedge angle is 30-degree. So it show here the angle, the thick ends is correct. Then I duplicate and oppose the beam to lateral side, and then now I will calculate my plan to see the difference with and without wedge. Okay, so now it's not really homogeneous because the lateral beam contribution is more than the midline here, so I will adjust a bit. Okay. So now the goal of the breast dose distribution is 95% coverage on the chest wall, which means this here, the curve here is cover 95%. So actually this beam, this plans is considered okay, because the 95% is good coverage compared to just now the before wedge. Let me show you the difference. Okay, you can see here, this plan is before wedge. We can't push the red color dose is actually 107%. So we can't reduce this if we didn't put the wedge dose. My doctor tried to remote. Okay. So okay, after I put in the wedge 30 degree, you can see obviously the red color dose here, the 107% is now gone. So my maximum dose is now 42.5 gray. So 42.5 gray divided by 40 is 106%. So it's already fulfilled our criteria. So the wedge play a very important role in fill technique. Before I go further, is there any questions? Do you understand how do we apply the wedge technique here?
Yes, Miss, we understand.
Yes, Miss.
Understand, So now I'm going to show you a different things. Okay, where you can see, I cannot show you here. Okay, wait. Before we put in the wedge, the prescription, the monitor MU for a plan without a wedge is 293. You mark this down, 293 MU. So when we put in the wedge 30 degree, the dose, the monitor MU jump from 300 to 600 MU. This is considered very normal because when you apply, you want to push in the hot spot to reduce the hot spot when you use wedge technique, motorized wedge technique. So this is very normal. So now I'm going to show you another planning technique where we call fill in fill technique. We actually don't use the wedge technique. In my center, we are seldom to use the wedge technique because as you know, as higher the monitor unit, the treatment time will be higher. So in my center, we will try to reduce the usage of the wedge. So in you can save time also because the collimator no need to turn here and there. The MLC no need to move in here and there. So now the technique is called fill in fill technique. It's actually similarly to the IMRT technique where it used the MLC segment to shield off the hotspot. So this one is called mini IMRT, like I can say. This one is we call fill in fill. Fill in fills as in this fill in fill technique. This one. Some center may not know how to apply it yet, but I wish to teach you all first because this one I find it quite useful and save quite a lot of time in terms of patient treatment delivery. So, okay. So how do we do this fill in fill technique? The fill in fill technique is aimed to reduce the hotspot. Remember just now I said I want to reduce the now is the 10% to 7%. I want to get rid of this red color dose distribution. So at first I will need to I will need to turn it off at this DRR. So now I will copy my beam, this right media. Then I will start to show the hotspot accordingly to what it shows here. by using the MLC. So for this machine, I choose is a 1 cm MLC. 1 cm MLC. For the another machines will be a 0.5. So I use the MLC to shield off the hotspot. Okay, once after you shield off, you can oppose your beam. So you can see here is the another beam is also already shield off the hotspot. So now you can rename it as whatever you want lah. For our center, we will use like this so everyone is understand what is this. So now the rating is still 0, 0. I will calculate first. It's already calculated, sorry. So now how many percent rating I want to contribute from the field in field technique. For terms of rules lah, it's not more than 3%. It depends on what case. So from this case, I will start it first from 2%. Each field in field technique beam, I will put in 2%. Okay, and then I calculate. Okay, now the 107% dose is disappear by applying to a total 4% from the field in field technique. But as you can see at the right pane here, there is still a small spot there. The 107% is still there where it shows here. Let me turn. Yes, here. So we may try to increase the weighting. Okay, increase already is still not enough. It's still showing some spot there. You can still playing the weighting. Okay, now it's almost gone. It's a little bit dot there only, which I think it should be okay. So at the end, the 95% coverage is still there. Of course, you can make it hotter by putting the weight point, the prescription point into deeper. But for this scenario, I can put in deeper. Wait, let me see. Right. Okay, I can move my point. Whenever you move your prescription point, the 100% will follow, will be that point lah. So I want to move it deeper. And now I already moved in deeper from the, you can see the difference from the orange color 100% to the light purple point there. So after I change my prescription point to that particular point, you will see, pay attention to the 100% color those there. When I click, it will straight away change. Okay. Then now, when I put it deeper, my 95% coverage is actually cover better, comparable to just now the wedge plan. But now my hotspot is coming back, so you can do more. Okay, let me go back 0% first. Okay, so you can assume we start from beginning. We want to shield back the hotspot. Of course, if you use your laptop to see, it's very difficult to show off lah. because the monitor is very small. So normally the setting actually is a 29-inch monitor. If you can zoom in better. So okay, now I already show off the hotspot, and then I put the weighting 3 to 3. Okay, calculate. Okay, now the hotspot 107% is all gone. So it's already fulfilled the criteria, the archaeology criteria, and the 95% coverage is very nice now. So what am I trying to show you here is when you compare just now the wedge plan, the total MU is 606 MU. But while we use the fill in fill technique, the total MUs is actually almost same as the without fill in fill technique is only 304 MU. The first plan when we do nothing to shield the hotspot is 293 MU. So after we use the wedge technique, the MU will increase to 606. But when we apply the fill in fill technique, the MU is only half of the wedge technique, which is 300 compared to 600. What I want to emphasize here is with the fill in fill technique, we can achieve the similar dose distribution while the MU perfection is reduced to half. So this one is the fill in fill technique fill, and this one is the wedge plan. So you can actually see the dose coverage of 95% and the 100% coverage is actually almost similar. And how about I show you the 50%? 50% is the same. The 33% is the same. How about the 10% dose? Is almost similar. So this is what we try to save the patient delivery time from 1 minute to half a minute. So this is a very good technique when you apply in your center. But unfortunately, it's not every center is using this technique yet, because maybe they don't know, they don't have a senior to teach them. Because when I first used this technique, where I learned I learned this technique back then to 2010, year 2010. There is a foreigner lah, when I attend a conference at I think it's at Beijing, they teach this technique. So when I come back, we start to try to play around this, and then we found it's very much useful. And those days the radiographer need to put in the physical wedge, and then after we apply this one, we actually really save a lot of times for the whole day and the patient delivery times. So after that we will after then I try to teach my friends, my colleagues for this technique, but unfortunately I don't really know the government side physicists. So I try as much as possible, I will teach this technique to the others physicists lah. But from this, you can really see the benefit of the field in field technique. So I hope this field in field technique you learn it now, and then when you become a physicist, you can teach the other center where I'm not sure how many center is practice these things here. Because actually if you put in the wedge, the planning time is much more faster than you use the field in field technique. Means the field in field technique you use more time to plan lah, but the planning time is only one time. You need to remember the patient is coming for 15 fractions, so 15 fractions times half a minute is maybe it's not more, it's about 7 minutes, but it's definitely reduce patient delivery times and also actually the whole workflow. So because this patient already saved half a minute, it may reduce the other patient waiting times too. So I hope this one, actually the concept is just a IMRT concept, is using the MLC segmentation to reduce the hotspot. So I hope you can learn this and you remember this technique, and maybe next time when you go to other center, I hope they already apply this technique. So far, is there any questions? My breast
Hello,
field
Miss.
already finished here. Yes.
Hello, Miss.
Yep.
I have one question. Uh, it do this Filipino technique use for PMRT, post mastectomy radiotherapy?
You can apply this field in field technique in any plan. It doesn't matter in breast or any plan lah. Prostate, thorax, any plan you things you want to reduce the hotspot, you can just use this field in field technique.
Okay, I say how about bolus?
Bolus you want me? Okay, I show you the bolus. I forgot.
Okay, thank you.
So for this, before I jump to the bolus effect, is there any questions else for this wedge and field in field, or for the breast planning?
No, miss, I can understand for what you are explaining.
Okay, so now I will create a field with my field in field plan. Okay, with applying bolus. So for this planning system, before I apply the bolus, I need to contour the bolus contour the bolus first. Of course, if doctor already decide they want to use the bolus for the treatment, when the radio simulation, they can straight away apply the bolus while doing the simulation. So when they scan the patient with the bolus, they will straight away see the bolus here. So if not, we will create like a so-called dummy bolus here first. So let me create first. Let's say our situation, we need 1 cm bolus lah. So you will need to put in a 1 cm thickness here. So you have to define where is the start point of your bolus. For Monaco, if I'm not wrong, if you start point to the end point is clockwise. Let me see. Seldom do breast, so I forgot. Okay, define end point means the bolus will apply from here to there, and then from which area you want to cover the top point until the bottom point. It's okay when you contour the bolus is bigger than your field, because it's only applied to the treatment area. calculations. So now I already generate the bolus. Okay, let's save first. Okay, now I want to take account the bolus effect into my calculations. So for the treatment planning system, you have to make sure you click the bolus here, else the calculation won't take effect into the patient's MU. So you need to click bolus for all. This one won't link because sometimes doctor will only say posterior only I want the bolus. So you will just apply the bolus at posterior field. So the bolus treatment aids here, you won't they won't have a link like the photon, the energy. So you have to take each one, the which beam you want to apply the bolus. So now after I apply, so now I calculate. So the bolus effect, if you increase the surface dose, so in some situation the tumor is more superficial, because when we know the 6 MV Dmax is 1.6 cm. So how about at 1 cm depth or 0.5 cm depth? It's definitely will less than 100%. It's maybe a 50% dose. So okay, as you can see here, let me save. Okay. So of course, this plan, after you apply the bolus, the hotspot will come back because they dump all the dose to increase the dose at the superficial, the surface of the patient breast. So now you can see all the 100% is now covered. Let me there. Wait. Okay. As you can see, before we apply bolus, the patient's skin is only okay. The patient's skin here. I need to zoom in. Okay. The patient's skin here is only received 30 gray, while after we apply a 1 cm thickness, the patient's skin at the same point receive 41 gray now. The previously is only received 30 gray. This is because our at 0 cm depth for 6 MV, the PDD, they are just the dose is just started to, this is the PDD depth. Okay. At this 1.6 cm, we get 100% dose at this point. So at 0 cm and 1 cm, maybe it will only get 60% at the 1 cm depth, and 0% is zero lah. It's not exactly zero lah. It's actually very low dose lah. This is why after we put in the bolus, we are like trick the treatment planning system. Our Dmax here will calculate from the bolus point to here 1.6 cm Of course, this plan the prescription points is at different place lah. So at the usual plan at 1.6 cm depth from the bolus, this point actually get 100%. I can show you the difference, but can you understand now? Else I will show you the max point for the bolus. Can you understand now?
Yeah, so far I understand.
So I no need to show the bolus Dmax.
Yeah, thank you.
So after the bolus effect, the skin will definitely very high dose lah. So we will see at the end of the treatment, the patient skin actually will be a bit sunburned. Some patient is redness, some patient is dark brown colors, but we already expect that one because we want to boost up the surface region with the higher dose. So, any questions so far? Because I already finished all my sections.
Miss, I have one question. In your center, what kind of bolus did you use?
What kind of
What kind of bolus is it? The super flat,
Yes,
normal, flat,
yes.
that one, right?
It's a
Okay,
30 cm times 30 cm.
super
Let
flat.
me show you. Wait, you can see my screen, right?
Yeah.
I can show you the example. Bolus. In case of other student do know what kind of bolus we use, the standard is this type. They make the bolus material equivalent the equivalent density to 1, which equivalent to our soft tissue equivalent dose the density is 1. So actually for breast we will use this one. For the others customize, we can actually use the white gauze, where when you injured we put the white gauze we just wet it up, put in the water because water is water equivalence one the ed is will be 1 so we will use that type also. And the other types the now very Chang'e one, they all have the 3D printed bolus, but it's quite costly, so we don't invest this type of device here because not very frequent we use the bolus. So sometimes we also use dental wax. If you do how to say there is a type of material in dental clinic lah. There is type of bolus also which we can customize the patient bolus into like this green colors according to patient shapes. If you have maybe if I remember next time I can show you image. I don't have and what the example of the bolus is just these 3 types lah so far what we use in our center. Okay, other questions? There's one questions here. What does it mean by OFF and under 2D of the I don't understand these questions Can anyone try to explain what questions is she asking? The question, oh sorry, the questions come to me private. I type it here. The question is this, but I don't understand what actually she is asking. Anyone can try to explain to me?
Is it something on your screen?
Sorry.
At the TPS system, is it? I'm not sure as well what is the question. But is she
I don't
actually
know what
asking?
is the OFF. I'm not sure. Maybe this student you can explain to your lecturer, and then your lecturer can forward to me afterward. Okay, any questions else? Because our time is just nice at 12:36 p.m. now. So if there is no questions, I would like to end of my presentations here lah. It's quite a very tired presentation. I hope the student can accept, can understand as much as possible, and they can absorb it lah.
Any question to Miss Teo? I've actually put the form. Please fill in the feedback form. Any comments that you would give, and also if you have any further question, you can post it in the form. Then I will ask the question directly to Miss Teo, or maybe Miss Teo can answer the question next week, because we have another session next week.
Yes.
Yeah.
Next
so
week
maybe
will be a tougher one.
yeah. I think
Please,
it's getting
please
complex,
read
more
first.
yeah. Maybe perhaps if you can give like an outline, because I did not receive the outline for next week yet, so I can forward to the.
I'm trying to make it as simple as I can.
Okay.
Displaying contour line. I don't understand as well. Okay, no questions.
Okay, if there is no question, thank you so much, Ms. Teo. I hope that the students can at least grasp the idea of it, how you do treatment planning for each of the cases.